Okay, so let's get into it. So with that discussion in our consciousness now, we now realize that manual muscle testing in the AMA guides is a huge topic. And I would love to have double the time, and I may expand on this program in the future, but for our purposes now, in order to illustrate some of these procedures, let's narrow our focus down to Chapter 15 and Chapter 17. And I choose Chapter 15 to be exemplary and illustrative of the procedures involved with testing specific muscles. And then we'll get into Chapter 17 and we'll focus on manual muscle testing of specific motions. And between the two of those sections, you'll have a good idea as to the procedures involved, and you'll be familiar with the procedures involved of manual muscle testing, regardless of whether you're testing specific muscles or you're testing specific motions. So let's begin now with Chapter 15. I've reprinted for you Table 15.2, and we're going to be testing muscles that are innervated by the brachial plexus. And you'll recall that the brachial plexus involves the nerve roots C5, C6, C7, C8, and T1. And if you go back to your training in anatomy, you'll remember that in the cervical spine, the nerve root comes out above the named vertebrae. So for example, the C1 nerve root comes out above the C1 vertebra. The C2 vertebra comes out above C2, comes out between C1 and C2. So with the C5 nerve root, that comes out between C4 and C5. The C6 nerve root comes out between C5 and C6. C7 nerve root comes out between C6 and C7, and etc., with the T1 nerve root coming out between T1 and T2. Now this is unique to the cervical spine. In the thoracic and the lumbar spine, the nerve root comes out below the named vertebra. So for example, the L5 nerve root comes out below L5, between L5 and S1. So the C5 nerve root, for example, can be involved in the case of a C4-C5 disc herniation, or cases where there's stenosis or osteophytosis at the C4-C5 level. And for that level of the spine, we're going to be testing the deltoid muscle. For the C5, for a C6 nerve, we're going to be testing the bicep muscle. For C7, we're going to be testing the wrist flexor muscles, and that includes the flexor carpi ulnaris and the flexor carpi radialis muscles. For C8 nerve root, we're going to be testing the finger flexor muscles, and that includes the flexor digitorum superficialis and the flexor digitorum profundus. And then for the T1 nerve root, we're going to be testing the hand intrinsic muscles, which includes the dorsal and palmar interossei muscles. So let's talk about the deltoid muscle then, and let's get into the manual muscle testing now, finally, of all these muscles. Okay, so let's begin with the deltoid muscle. And the deltoid muscle is representative and pathognomonic for the C5 nerve root. And as I discussed earlier with regards to the myotomes, the deltoid muscle is not exclusively innervated by the C5 nerve root. In other words, it's also innervated by the C6 nerve root, meaning that portions of the deltoid muscle contain cells that came from the myotome of the 6th cervical somite back during gestation. but the deltoid muscle is largely innervated by C5. It's predominantly innervated by C5. And in the case of a C5 nerve root lesion, the deltoid muscle will present varying degrees of weakness. The deltoid is also innervated by the axillary nerve, and so the deltoid may be a muscle that you could be involved with in the case of an axillary nerve injury. The axillary nerve is a peripheral nerve, it's not a nerve root. But under Chapter 16, in the case of an axillary nerve injury, you may also be evaluating the deltoid, as the deltoid is involved in specific motions. Okay, so the deltoid has three parts to it. There's an anterior, middle, and a posterior deltoid. The anterior deltoid originates on the anterior and superior surfaces of the lateral third of the clavicle. So it has a clavicle origin. The middle deltoid originates on the lateral superior surface of the acromion, and the acromion is part of the scapula, so it has a scapular insertion, or I'm sorry, a scapular origination. And then the posterior deltoid originates from the inferior lip of the spine of the scapula, if you can picture that in your mind, the inferior lip. The spine of the scapula, of course, has two lips. It has a superior lip and an inferior lip, and so the posterior deltoid attaches on the inferior lip. Okay, then the anterior deltoid, the middle deltoid, and the posterior deltoid all have common insertion, and they all insert on the deltoid tuberosity of the humerus. And I want to just emphasize here that if you remember back to osteology, the deltoid tuberosity is a ridge on the humerus bone, and it bears reviewing the anatomy of the humerus bone, because if you look up the humerus bone in one of your pictorial atlas books, you'll note that the deltoid tuberosity is much more inferior down the length of the humerus bone than you might visualize in your mind. The deltoid tuberosity comes approximately midway down the length of the humerus bone, and that's kind of enlightening, especially when you think about a bodybuilder who has hypertrophied deltoid muscles. Those deltoid muscles and the belly of those muscles appear very high up on the humerus bone, but the insertions of the three heads of the deltoid muscle actually continue down to about the mid shaft of the humerus. And so for those of you that have your handout materials, I have some anatomic depictions here with some indications as to the attachment of the anterior deltoid on the clavicle, the middle deltoid on the acromion process of the scapula, and then the posterior deltoid originating from the inferior lip of the spine of the scapula. The deltoid muscle is a multi-pennate muscle. If you remember the concept of muscle pennation is a way for a muscle to be able to stack more muscle fibers and therefore more sarcomeres and more contractile elements into the same surface area, thereby contributing to greater strength. So the deltoid is a broad muscle at the top, tapering down as the insertions of the anterior, middle, and posterior delt all converge on the deltoid tuberosity of the humerus. And I have some diagrams here of the deltoid muscle, and it really gives you a good idea as to the angle of pull of the three portions of the deltoid muscle. The three portions of the deltoid muscle are tested during shoulder joint abduction in the coronal plane, and in many cases simply testing shoulder joint abduction in the coronal plane will be sufficient to test the deltoid muscle. Now, each of the three heads of the deltoid muscle can be broken out and tested individually, and we'll go over that here now. So to individually test the anterior deltoid, we need to know the action of the anterior deltoid. So the action of the anterior deltoid is to flex the humerus in the sagittal plane to 180 degrees. It also horizontally adducts the shoulder when the shoulder is in a position of 90 degrees of shoulder abduction. So it flexes the shoulder straight forward in the sagittal plane, and then it also horizontally adducts the shoulder when the shoulder is in 90 degrees of shoulder abduction. And that kind of resembles the bench press maneuver, right? With a bench press maneuver, you start with your hands on the bar, you bring the bar down to your chest, and now your shoulder is now in approximately 90 degrees of shoulder abduction. And as you press that bar overhead, that maneuver at the glenohumeral joint is horizontal adduction, and that's done primarily by the anterior deltoid, also in conjunction with the pectoralis major. So the anterior deltoid is tested in a sitting position, and in the sitting position you have the subject first go through the above ranges of motion, meaning you have them flex their humerus to 180 degrees, you have them go through shoulder horizontal abduction, and then you apply the manual muscle testing portion of the resistance, first by stabilizing the opposite shoulder or the ipsilateral scapula, depending upon the strength of their scapular stabilizers. If they're strong, you can stabilize the opposite shoulder, or in the case of weakness of scapula stabilizers, you would want to stabilize the ipsilateral scapula. Then with the subject's arm in 90 degrees of flexion, you apply resistance proximal to the elbow, and push the shoulder into a combination of extension and horizontal abduction, abduction, away from the muscle's natural movement to try to pull the shoulder into horizontal adduction. So you would resist horizontal adduction by pushing the arm into horizontal abduction. Okay, and then to test the middle part of the deltoid, we need to know the action of the middle deltoid. The middle deltoid abducts the shoulder to 90 degrees in the coronal plane, kind of like doing a standing side lateral maneuver in the gym, which you would do with dumbbells. That coronal plane abduction to 90 degrees is the job of the middle deltoid. So to test the middle deltoid, you ask the subject to go through the range of motion of coronal plane abduction to 90 degrees. Then you add the manual resistance portion of the test by stabilizing either the opposite shoulder or the ipsilateral scapula. And with the subject's arm in 90 degrees of abduction, the resistance is applied proximal to the elbow to push the shoulder into adduction, which is toward the body, meaning toward the hip. You push the shoulder downward into adduction toward the hip. Now you have to be careful with this movement to detect any possible substitution. If the shoulder goes into any degree of external rotation, that indicates that your examinee is attempting to substitute the biceps brachii for the action of the middle deltoid. So that would be an evidence of a substitution movement if you're able to observe the shoulder to be able to begin to rotate into external rotation. Now for the posterior deltoid, the job of the posterior deltoid is horizontal abduction in the transverse plane from a flexed position of 90 degrees. So I want you to just recreate this movement for me here. Take your shoulder and flex it forward to a position of 90 degrees. That is with your arm straight out in front of you, level with the shoulder, flexed to 90 degrees. It's the job of the posterior deltoid to then move that elbow backwards and behind your body. That's horizontal abduction from a position of 90 degrees of shoulder flexion. So to test the posterior deltoid, ask the subject first to go through the range of motion of horizontal abduction. Once they're able to complete that, you then go through the resistance added portion of the manual muscle testing by stabilizing either the opposite shoulder or the ipsilateral scapula. Then with the subject's arm in 90 degrees of forward flexion with the elbow flexed in slight extension. Well, let me change that. Let me correct that. With the subject's arm in 90 degrees of abduction, not flexion, abduction, and with their elbow flexed, and in slight extension and with slight internal rotation of the humerus, the resistance is applied proximal to the elbow and posterolaterally to the elbow to attempt to push the shoulder into horizontal adduction, which is towards the body, and slight flexion, which is towards the front of the body. Okay? So by attempting to push the shoulder in horizontal adduction, we are testing the posterior deltoid, which moves the arm in horizontal abduction. Okay, so that's quite a bit of detail about the deltoid muscle, some of which may or may not be necessary. It may be simply sufficient to test the three heads of the deltoid muscle in resisted horizontal abduction. But here's some more detail should you really need to probe deep in order to expose a small weakness of the deltoid muscle. Okay, so with a grade 5 of the deltoid, what would you expect to see? Well, the patient or the examinee would be able to abduct the arm to 90 degrees and would be able to hold against added resistance. With a grade 4, the examinee would abduct to 90 degrees and would be able to hold against some added resistance, maybe not maximal added resistance, but against some. With a grade 3, the examinee would be able to abduct the arm to 90 degrees, but would not be able to hold against resistance. With grade 2, the examinee would be able to abduct the arm in the side-lying position only. In other words, not able to do the movement against gravity, or would be able to do only a partial range of motion in the upright anti-gravity position. And then with grades 1 and grade 0, there would be slight to no contraction of any of the fibers of the deltoid muscle. And recall that grades 2, 3, and 4 can be modified to indicate better or worse performance. Okay, for testing the C6 nerve root, we're going to use the biceps muscle. Now, again, the bicep muscle is not exclusively innervated by C6. It's innervated by multiple nerve roots, but it's largely innervated by C6. And in the case of a C5, C6 nerve root lesion, I'm sorry, a C5, C6 disc lesion that affects the C6 nerve root, we may see varying weaknesses of the bicep muscle. Now, the bicep muscle has two heads. That's why it's called the biceps. The long head originates on the supraglenoid tubercle of the scapula. And the supraglenoid tubercle is at the immediate superior aspect of the glenoid fossa of the scapula. So the long head crosses the glenohumeral joint to attach on the upper part of the glenoid fossa of the scapula. The short head attaches on the coracoid process of the scapula, and there are other muscles that share the coracoid process of the scapula. In fact, there's three muscles that attach to the coracoid process of the scapula. One is the short head of the biceps, another is the coracobrachialis muscle, and a third one is the pec minor muscle. So the bicep muscle, a two-headed muscle, comes down the humerus bone, and those two heads combine into one, and they have common insertions, plural, onto two bones. There's a radial insertion where the bicep tendon attaches on the radial tuberosity. And then there is a connective tissue aponeurosis from the bicep tendon that attaches onto the volar medial aspect of the ulna bone. And this aponeurosis is called either the bicipital aponeurosis. Also, sometimes you'll see it referred to in textbooks as the lacertus fibrosis. And for those of you that have the PowerPoint presentation, I have here some anatomic diagrams to indicate the origins of the bicep muscle. The coracobrachialis is indicated in red, and the supraglenoid tubercle of the scapula is also indicated in red in another diagram. And what's interesting about these insertions is that these insertions are not on the humerus bone. In other words, the bicep muscle, both heads, cross the shoulder joint at various points, cross the glenohumeral joint at various points to attach on different points of the scapula. So the bicep muscle is actually a triarticular muscle that has action at the glenohumeral joint, has action at the radial humeral joint, and then because of its attachment onto the radial tuberosity, it also has action at the radial ulnar joint. So it's quite interesting that the bicep is a triarticular muscle, and therefore subject to frequent injury, especially at its proximal attachment onto the supraglenoid tubercle. Also here are some diagrams of the bicep muscle which clearly show that it's a two-headed muscle. The short head, which attaches on the coracobrachialis, is the more medial of the two, and that makes sense since it's the coracobrachialis that is more medial. No, I'm sorry. Since it's the coracoid process that is more medial than the supraglenoid tubercle is. And then distally we see the attachment of the bicep tendon into the radial tuberosity, with the bicipital aponeurosis coming off the bicep tendon and stabilizing the bicep by attaching it to the medial aspect of the ulna. And you can feel both of these structures in your antecubital fossa. If you simply flex your bicep muscle and feel down there, you can feel the bicep tendon itself, and then slightly lateral slightly medial to that, extending over to the ulna bone, the medial aspect of the ulna bone, you can feel the lacertus fibrosus. And those usually stand out in bold relief when you're doing strenuous exercises that involve resisted elbow flexion. Okay, so the biceps muscles have several actions. Both the long and the short heads assist with flexion of the shoulder joint, since they do indeed cross the shoulder joint. The long head assists with shoulder abduction if the humerus is externally rotated, and that makes sense that external rotation of the humerus exactly lines up the long head to assist with abduction. The short head, conversely, assists with shoulder adduction. Now, with the shoulder fixed, meaning the origin of the long and the short head fixed, both the long and the short head flex the elbow, moving the forearm toward the humerus, and also supinating the forearm. And with on the other hand, with the elbow fixed, meaning the insertion of the long and short head fixed, the long and short heads flex the elbow joint, moving the humerus towards the forearm, such as would occur in a pull-up maneuver. So the bicep muscle has different action depending upon which of the origin or insertion is fixed. So to test the bicep muscle, we're going to test the bicep muscle in the sitting position. And the first movement is to first have the subject go through the above ranges of motion, which are shoulder flexion, elbow flexion, and forearm supination. Next, we're going to stabilize the upper arm to prevent shoulder flexion, or especially to prevent shoulder extension, which can give us the erroneous impression of elbow flexion. Then, with the subject's elbow in 90 degrees of flexion and fully supinated, apply resistance proximal to the wrist to push the elbow in extension. For very weak individuals, you may move your resistance closer to the elbow. With very strong individuals, you may move your resistance distal to the wrist. However, caution needs to be applied to make sure that other muscles are not recruited into the action. Now, in the event of weakness of the bicep muscle, the examinee may attempt to substitute other motions to give the appearance of elbow flexion. Especially, they may extend at the shoulder, and extension at the shoulder causes passive flexion at the elbow, and that may give the appearance, the false appearance, of active elbow flexion. Also, be careful with the wrist and finger flexors, because both the wrist and the finger flexors originate on the humerus bone at the medial epicondyle, and those muscles can contribute to elbow flexion. So you reduce their contribution by ensuring that the subject relaxes the wrist and relaxes the finger flexors by maintaining an open hand, and in that way we can isolate specifically the bicep muscles. So how would this appear? Well, with a grade 5, the examinee is able to flex the shoulder, flex the elbow, is able to supinate the forearm throughout full ranges of motion, and then is able to hold the position against maximum added resistance. With a grade 4, they would be able to complete all the same ranges of motion, but only with slightly less resistance. grade 3, they're able to go through full range of motion without added resistance. For grade 2, they're able to go through full range of motion only in the anti-gravity position, or they're able to go through only partial range of motion in the gravity position. In the anti-gravity position, or through full range of motion in the gravity eliminated position. And with grades 1 or grade 0, there would be slight to no muscle function remaining. And the bicep muscle is a good muscle to be able to detect in the absence of muscle function because of the superficiality of the bicep tendon in the antecubital fossa. So for grade 0, there would be no visible or no palpable contraction of the muscle in the antecubital fossa. Okay, for C7 nerve root injury, perhaps due to disc lesion at C6, C7, we're going to use the Flexor Carpi Radialis muscle. Now, the Flexor Carpi Radialis muscle is innervated by the median nerve, and as you know, the median nerve has contributions from many nerve roots. I believe it's all nerve roots, C5, C6, C7, C8, perhaps without T1, or it's either C6, C7, C8, and T1. In other words, many nerve root contributions. So that tells us that the Flexor Carpi Radialis receives muscle cells from multiple myotomes. However, we consider and we use clinically the Flexor Carpi Radialis muscle to be largely indicative of function of the C7 nerve root. So the Flexor Carpi Radialis muscle has its origin from the common flexor tendon on the medial epicondyle of the humerus, and then also has an attachment in the deep antebrachial fascia. And its insertion is onto the base of the second metacarpal bone, and then it also has a slip to the base of the third metacarpal bone. So if you look down at your hand and your wrist, you'll remember that the carpal bones form the wrist, and then on the far side of the carpal bones are the metacarpal bones. And so the Flexor Carpi Radialis attaches at the base of the second and third metacarpal bones, thereby shortly crossing the wrist and acting as a wrist flexor. And for those of you that have the PowerPoint, I have a diagram here that shows the origin of the Flexor Carpi Radialis on the medial epicondyle and the insertion of it into at least the base of the second metacarpal, even if the third metacarpal is not shown well on this diagram. So the Flexor Carpi Radialis actually crosses two joints. It crosses the wrist joint and it crosses the elbow joint. And so therefore it has actions at both joints. And for those of you that have the PowerPoint, I have here some diagrams, muscle diagrams of the Flexor Carpi Radialis muscle, and it attaches both at the elbow, at the medial epicondyle, and then crosses the wrist to attach to the base of the second metacarpal bone. And in these diagrams here, the Flexor Carpi Radialis is best demonstrated here by this one cut tendon here, and then over in this diagram is represented by this muscle here with the long tendinous slip. Now, the flexor carpi radialis muscle is quite interesting. It has multiple actions. It, of course, flexes the wrist, true to its name, but it also abducts the wrist. Now, abduction of the wrist is also known as radial deviation, and as you stand in anatomic position with your palms facing forward, radial deviation is movement of the wrist away from your body. So that's also known as wrist abduction. And it contributes to wrist abduction because of its location of its tendon as that tendon passes through the wrist. It's located in the flexor compartment of the wrist, but it's located laterally through an axis that goes through the center of the capitate bone. So because the center of the axis of rotation of the wrist is about the capitate bone, the flexor carpi radialis creates a moment arm that is lateral to this center point through the capitate bone. So it is a weak radial flexor. It's a strong flexor, but it's a weak radial deviator, or it's a weak abductor. In addition to those actions at the wrist, it also assists with pronation of the forearm. And then because it does indeed cross the elbow and attach on the medial epicondyle of the humerus, it does assist with flexion of the elbow. So the test position for the flexor carpi radialis is sitting with the forearm resting on a table. And make sure that the fingers remain relaxed so that finger flexors are not recruited in the movement. First, have the subject or examinee go through the above ranges of motion, which are wrist flexion with wrist radial deviation, and elbow flexion, and forearm pronation. Second, you're going to stabilize the forearm against the table or against some solid object. Then, with the subject's arm resting on the table and the wrist in slightly less than full supination, resistance is applied to the thenar eminence, and you apply resistance to the thenar eminence to get as close as possible to the insertion of the flexor carpi radialis onto the base of the second and third metacarpals. And then the resistance is applied in the direction of extension towards the ulnar side. In other words, in ulnar deviation, or in the direction of wrist adduction, adduction. Now, in the case of some weakness of the flexor carpi radialis muscle, you may detect some substitutions. For example, the subject may hyperextend the wrist and then relax the wrist, giving the false appearance of wrist flexion. Or the substitute may try to incorporate the use of the finger flexors. And we'll talk about the finger flexors in a minute. The finger flexors do contribute to wrist flexion. In order to eliminate the involvement of the finger flexors, make sure that the fingers stay relaxed. So for a grade 5 of the flexor carpi radialis muscle, what would we expect to see? Well, the examinee is able to complete full range of motion and holds the end position against maximum added resistance. For grade 4, they have same. However, they may have some slight decrease in strength of wrist flexion. They might have some decreased in pronation strength of the forearm. They may have some decrease in strength of wrist radial deviation. For grade 3, we may see that they're able to complete range of motion, but they're not able to hold that range of motion against added resistance. And to observation, we might notice a slight ulnar deviation of the hand, and that would be a positive objective finding that would contribute to your conclusion for a grade 3 muscle grading. For grade 2, the subject would be able to complete some range of motion in the gravity eliminated position. Now, with testing of the wrist and the hand, the distinction between anti-gravity and gravity eliminated positions is not as great as it is for other portions of the extremities tested, because the weight of the wrist and the hand is almost negligible. So the change from the gravity, the anti-gravity to the gravity eliminated position is not much. So for grade 2, the main objective finding would be that the subject is able to complete only some range of motion, not able to complete complete range of motion. And then for grades 1 and grade 0, we have increasing weakness and perhaps a slight or even absent contraction of the muscle to be noted. Okay, moving on to the C8 nerve root, and this is fascinating. I love this anatomy. For the C8 nerve root, we rely on manual muscle testing of the finger flexors. Now, there are two main finger flexors. There is the Flexor Digitorum Superficialis, and then we have the Flexor Digitorum Profundus. And we consider these muscles to be innervated by the C8 nerve root. Now, interestingly, they both are innervated by C8, but the C8 nerve root going to the Flexor Digitorum Superficialis gets there by traveling in the median nerve, whereas the C8 nerve root going to the Flexor Digitorum Profundus, at least to the portion of the Flexor Digitorum Profundus that goes to the ring and the pinky fingers, gets there by traveling in the ulnar nerve. So while both of these muscles are innervated by the C8 nerve root and are representative of the C8 nerve root, they get to the target destination by traveling in different peripheral nerves. Now, the median nerve brings innervation through the C8 nerve root to the entirety of the Flexor Digitorum Superficialis, but only to the index and middle fingers through the Flexor Digitorum Profundus. The ring and pinky fingers of the Flexor Digitorum Profundus, that portion of the muscle, is innervated by the ulnar nerve, by C8 fibers traveling in the ulnar nerve. So some fascinating anatomy and some fascinating neurology here. Just recall that the Flexor Digitorum Profundus muscle has two functional divisions. It has two tendons that go to the index and middle fingers, and it has two tendons that go to the ring and pinky fingers, and those two divisions have different innervations, being the median nerve and the ulnar nerve respectively. But we consider both to be innervated and representative of C8 nerve root function. Okay, so let's talk first about the Flexor Digitorum Superficialis. The Flexor Digitorum Superficialis has three origins. It has an origin on the humerus, it has an origin on the ulna, and it has an origin on the radius. So on the humerus, note that the humeral origin crosses the elbow joint, so that makes these muscles elbow flexors, even if they are only weak elbow flexors. And that explains why so many people have medial elbow pain from doing heavy exercises that involve their fingers, such as pull-ups. With a pull-up, you have to grip the bar tightly, otherwise you can't hang on. And then you flex the elbow and the finger strongly and really drag those tendons tight across the humeral origin, contributing to medial elbow pain. So at the humerus, the flexor digitorum superficialis attaches on the medial epicondyle by way of the common flexor tendon. It also sends a slip to the ulnar collateral ligament and then also a slip to the deep antebrachial fascia. On the ulna, there's an attachment to the medial side of the coronoid process, and then on the radius, there's an attachment to the oblique line of the radius. And then as the muscle travels down in the forearm, it inserts by 4 tendons into the sides of the middle phalanges, not the proximal phalanges, not the distal phalanges, the middle phalanges of the 2nd through the 5th digits. No insertion into the thumb. The flexor digitorum profundus has its origin on the anterior and medial surfaces of the proximal 3/4 of the ulna into the interosseous membrane, and then also into the deep antebrachial fascia. So the flexor digitorum profundus does not cross the elbow joint. Interesting. Interesting. Very interesting. So when people have that medial elbow pain from doing pull-ups, it's a tendinitis of the flexor digitorum superficialis rather than the flexor digitorum profundus. Interesting. And the flexor digitorum profundus then inserts by 4 tendons into the bases of the distal phalanges. So the tendons of the flexor digitorum profundus pass the tendons of the flexor digitorum superficialis to then attach onto the bases of the distal phalanges. And for those of you that have the PowerPoint presentation, I have several diagrams here that show these origins and insertions. There's a diagram that depicts the medial epicondyle. There's a diagram that shows the interosseous membrane. And I'd like you to take just a moment to look at the interosseous membrane. I recently was at a dissection lab at one of the local chiropractic colleges, and we had specimens dissected all the way down to the interosseous membrane, and it looks exactly as it's depicted here in this diagram. It's a thick membrane that's tough and prevents separation of the radius and the ulna from each other, but yet it's supple enough and flexible enough and slack enough to allow pronation and supination of the radius around the ulna. Here are some anatomic depictions of both the flexor digitorum superficialis, which crosses the elbow joint, and the flexor digitorum profundus, which does not. Here's a diagram showing the origins of the flexor digitorum profundus, which then attaches way distally into the distal interphalangeal joints. And so those are our finger flexors. And here's a close-up diagram that shows the attachment into the distal interphalangeal joints. So these are important muscles, especially if you're a rock climber or somebody who has to recruit strength from the distal interphalangeal joints as you position your fingers over the ledge of a rock or in between crevices or what have you. Okay, so the flexor digitorum superficialis acts to cause flexion of the proximal interphalangeal joints of the 2nd through the 5th digits. It also assists with flexion of the metacarpal phalangeal joints, and because the muscle crosses the wrist, or I should say the tendon crosses the wrist, it also assists in wrist flexion. Now the flexor digitorum profundus, its main job is to cause flexion of the distal interphalangeal joints of the 2nd through the 5th digits, and this makes it a unique muscle. It's the only muscle that flexes the distal interphalangeal joints. And so an injury to the tendon of the flexor digitorum profundus in the region of the distal interphalangeal joint can cause permanent weakness and dysfunction and lack of use of the distal interphalangeal joint. The flexor digitorum profundus also assists in flexion of the proximal interphalangeal joints, assists with flexion of the metacarpal phalangeal joints along with the flexor digitorum superficialis, and also assists with wrist flexion along with the flexor digitorum superficialis. So to test the flexor digitorum superficialis, we have our subject sitting with the hand resting on the table with the hand palm up. So the dorsal surface of the hand would be on the table. The wrist and the metacarpal phalangeal joints are held in neutral position, and first the subject goes through ranges of motion of flexion of the proximal interphalangeal joints. Then stabilize the palm of the hand, stabilize the proximal phalanx against the table, and make sure that the distal phalanx remains relaxed. Then resistance is applied to the palmar surface of the middle phalanx. Make sure you're on the middle phalanx in the direction of extension, meanwhile ensuring that the distal phalanx remains inactive. Now, in the case of weakness of the flexor digitorum superficialis, the flexor digitorum profundus may try to contribute by causing flexion of the distal interphalangeal joints, and that would be a substitution movement that you would be able to detect. To test the flexor digitorum profundus, the subject is going to be sitting again with the dorsum of the hand resting on the table. The wrist and metacarpal phalangeal joints are going to be in neutral, and the subject's then going to first go through ranges of motion of the distal interphalangeal joints of fingers 2 through 5. Then, with the wrist stabilized in slight extension, and with the proximal and middle phalanges stabilized, resistance is applied to the palmar surface of the distal phalanx, in the direction of extension. Now, substitutions with this maneuver are unlikely because this is the only muscle that flexes the distal interphalangeal joint, and so weakness to this muscle should be readily apparent. With grade 5 testing, or grade 5 scoring of the flexor digitorum superficialis, the patient is going to complete range of motion and hold against added resistance. With grade 4, we're going to see some loss of strength. We may see also some effect on activities of daily living, such as possibly some decreased grip strength, some decreased strength of wrist flexion, and some loss of activities of daily living for activities such as typing, such as playing the piano, such as playing stringed instruments that require strength of the proximal interphalangeal joint. With grade 3, the subject is going to be able to perform ranges of motion, but not against added resistance. And we're going to start to see objectively on physical exam some loss of joint stability of the proximal interphalangeal joints. And on certain movements of the fingers, such as with finger extension, you're going to see these joints start to hyperextend due to loss of stability over the anterior aspect of the joint. Grade 2, grade 1, and grade 0, we see increasing weakness. With grade 1 and grade 0, we see trace or even no contraction of either the muscle or the tendon of the flexor digitorum superficialis. With the flexor digitorum profundus, we have grade 5, which is full range of motion against added resistance. With a grade 4, we will start to see some loss of strength. There will also be some decreased strength of flexion of the distal joints of the fingers in direct proportion to the extent of weakness of the muscle, because this is the only muscle that flexes the distal interphalangeal joint. With grade 3, we're going to see some further weakness and now some loss of flexion strength of the proximal interphalangeal joints, the metacarpal phalangeal joints, and even strength of wrist flexion may be decreased because the flexor digitorum profundus contributes to flexion of these additional joints. With grades 2, grades 1, and grade 0, we see increasing weakness. And with grade 0, we're going to see either no visible and no palpable contraction of the muscle. Okay, finally, to complete our study of the brachial plexus, the T1 nerve root is tested through the intrinsic interossei muscles of the hand, including the palmar interossei and the dorsal interossei, both of which are innervated by T1 nerve roots that travel through the ulnar nerve. With regards to the palmar interossei, there are 4 palmar interossei muscles. We call those the pad muscles because they are the adductor muscles of the fingers, and they're located on the palmar surface of the hand. The first palmar interosseous muscle originates at the base of the first metacarpal bone on the ulnar side of the first metacarpal bone. So the first metacarpal bone, that's the thumb. And the first palmar interossei attaches on the ulnar side of the metacarpal bone of the thumb. The second palmar interossei originates on the ulnar side of the second metacarpal bone. The third interossei attaches on the radial side of the fourth metacarpal bone. And the fourth interossei originates on the radial side of the fifth metacarpal bone. So the pivotal point, the midpoint of the axis of the palmar interossei muscles is around the middle finger. And there are no interosseous muscles, there are no palmar interossei muscles that attach to the middle finger. They attach on each of the other 4 fingers, but none attach onto the middle finger. The palmar interossei muscles attach. The first one attaches on the ulnar side of the proximal phalanx of the thumb, and that makes sense. The second one attaches on the ulnar side of the proximal phalanx of the index finger. That makes sense. The third one attaches on the radial side of the proximal phalanx of the ring finger. And the fourth one attaches on the radial side of the proximal phalanx of the little finger. And that makes sense because these muscles are all adducting the fingers toward the middle finger. And so they originate and insert on the respective side of the middle finger that you would intuitively think would contribute to finger adduction, adduction, towards the midline of the middle finger. So I have here some diagrams to show the origins and insertions of the palmar interossei muscles, and indeed none of them attach or originate on the middle finger. And here's some muscle diagrams to show indeed there are 4 palmar interossei muscles, none of which attach on the middle finger, but all of which draw the middle finger, draw the fingers toward the midline of the middle finger. And that makes sense. Now, the dorsal interossei are slightly different. They have different function. They are finger abductors, abductors, and these are located on the dorsal aspect of the hand. So we call these the DAB muscles, the dorsal abductor muscles. So the first and second dorsal interossei muscles, they originate between each metacarpal on adjacent sides. So the first dorsal abductor muscle is between the first and second metacarpal. The second dorsal abductor interosseous muscle is between the second and third metacarpal. The third and fourth dorsal interosseous muscles attach between the metacarpal bones on adjacent sides, following the same pattern. So the third is between the third and fourth metacarpals, and the fourth dorsal interosseous is between the fourth and fifth metacarpals, attaching on adjacent sides of the metacarpal bones. And then those muscles insert on the radial side of the proximal phalanx of the index and middle fingers for the first and second interosseous, and then on the ulnar side of the proximal phalanx of the middle and the ring fingers, with no insertion on the pinky fingers. So here's a diagram here that shows the dorsal interosseous muscles, and indeed the first and second dorsal interossei attach on the first and second metacarpals. Third and fourth attach between the second interosseous muscles attach between the second and third metacarpals, etc. There is no attachment on the pinky fingers. However, the fourth dorsal interosseous muscle, fourth and fifth, well, it's actually the fifth, originates from the pinky finger but attaches onto the extensor expansion and the proximal phalanx of the fourth proximal phalanx. So the palmar interosseous muscles, they contribute to adduction of the fingers toward the axial line through the third finger, which is the middle finger, from a starting position of finger extension. They also assist in flexion of the metacarpal phalangeal joints and extension of the interphalangeal joints of the 3 fingers, excluding the middle finger. The dorsal interosseous muscles, they contribute to abduction of the index, the middle, and the ring fingers from the axial line, also through the third digit. So both of these muscles act around the axial line that passes through the middle finger. And the dorsal interosseous muscles also contribute to flexion of the metacarpal phalangeal joints and extension of the interphalangeal joints. And the first dorsal interosseous muscle also assists in adduction of the thumb. Okay, so let's get into testing these muscles. To test the palmar interossei muscles, first we stabilize the adjacent digits. Because the interosseous muscles attach on adjacent digits, we need to stabilize the adjacent digits to give fixation of the digit towards the finger that is moved, and to prevent assistance from the digit on the other side of the one that's being moved. So, for example, with the first palmar interosseous muscle, we are going to be testing resisted adduction of the thumb toward the index finger. So in order to do that, we hold the thumb and we pull the thumb in the direction of thumb abduction, which is in the radial direction. To test the second palmar interosseous muscle, we're going to be testing resisted adduction of the index finger towards the middle finger. In order to do that, we hold the index finger and pull in the direction of the thumb, which is away from the middle finger. To test the third palmar interosseous muscle, we're going to be testing resisted adduction of the index finger toward the middle finger. We're going to hold the we're talking here about the ring finger. We're going to be testing resisted adduction of the ring finger toward the middle finger. To do that, we hold the ring finger and pull in the direction away from the middle finger, or towards the pinky finger. To test the fourth palmar interosseous muscle, we're going to be testing resisted adduction of the little finger towards the ring finger. In order to do that, we hold the little finger and we pull in the ulnar direction away from the ring finger. And with strong palmar interossei muscles, we'll see that the subject is able to complete the range of motion against added resistance. With grade 4, we're going to see slightly less strength. This may manifest as a decreased ability to adduct the thumb, the index, the ring, or possibly even the little fingers. It's going to decrease the strength and flexion of the metacarpal phalangeal joints. We'll have decreased strength in extension of the interphalangeal joints, and decreased extension strength of the ring and little finger interphalangeal joints. With grade 3, we're going to see decreasing strength, flexion strength of the pips, the MCP, and the wrist may also be decreased. And with grades of 2, 1, and 0, we'll see only partial range of motion in finger adduction, and with grade 0, there will be no visible or palpable contraction of those muscles. With testing of the dorsal abductor muscles, we're going to start with the wrist in neutral position and the fingers in a position of slight extension. And the fingers that are not being tested are stabilized. So first we ask the subject to go through range of motion, which involves moving the index, ring, and little fingers away from the middle finger, and moving the middle finger toward the index and ring fingers. And resistance is applied to the side of the distal end of the proximal phalanx of each of the 4 fingers in a direction of adduction. Since the dorsal interossei muscles are involved with abduction, the resistance is applied toward the direction of deduction. And in the presence of strong dorsal abductor muscles, we'll see that each finger is able to complete the range of motion and to hold against added maximum resistance. Now this brings up an interesting point, and that is, what is maximum resistance for a dorsal interosseous muscle? Well, it's obviously very small, and you need to take that into consideration, and you need to use your own fingers in a similar fashion to test their fingers, and in that way, by comparing your finger strength to their finger strength, you get a good assessment as to their relative strength compared to yours. With a grade 4, we're going to see that range of motion is full, but strength is slightly less. Objectively, we're going to find that there's a decreased ability to abduct the index, middle, and ring fingers. There may be decreased strength of extension of the interphalangeal joints, decreased strength of flexion of the metacarpal phalangeal joints, of the index, middle, and ring fingers. With grade 3, the fingers are able to complete range of motion of finger abduction, although not against added resistance. With grade 2, we're able to see only a partial range of motion, and then with grade 1 and with grade 0, we see increasing motor deficit, increasing muscle deficit, and with grade 0, there will be absent visible or palpable evidence of contraction of the dorsal abductor muscles. And the dorsal abductor muscles lie deep between the metacarpal bones on the dorsum of the hand, so there will be no visible or palpable evidence of any contraction there. And this is able to detect, this is easy to detect when it's absent.